our big problem in access to new therapies in Canada is that we have more levels and kinds of gatekeepers than any other country on planet Earth. We have 5, and it's daunting. And that's why a lot of orphan drugs for rare diseases don't even bother coming to Canada. It's intimidating.
Welcome to Inside Policy Talks, the podcast for the Macdonald-Laurier Institute. I'm Sean Watley, a senior fellow at MLI. I'm a physician, and I also have a longstanding interest in health policy and health governance. Rare diseases affect only a small number of Canadians, but they expose some of the biggest issues behind healthcare itself, its strengths, its weaknesses, and some of the challenges that we face within healthcare more broadly. They raise hard questions about cost, access, fairness, and how we make decisions. They also give us a glimpse on how the Canadian healthcare system is able or unable to respond to challenges. Today, we'll look at what rare disease policy reveals about how Canada governs healthcare, what works, what doesn't, and what might need to change. To discuss this, I'm joined by John Adams. John is a senior fellow with MLI, a management consultant, and a respected public policy expert. He's also one of Canada's leading advocates for patients with rare diseases. John co-founded and leads CanPKU. He helped establish the Global Association for PKU and chairs the Best Medicines Coalition, which represents millions of Canadian patients. Drawing on his personal journey as a parent and a caregiver, John brings unmatched lived experience on drug access, rare disease policy, and health system reform. Now, before we start, please hit like or subscribe. It makes a big difference for the work that we do here. So, John, welcome.
Sean, it's wonderful to be here. I'm a rookie. This is my first time on this podcast, so bear with me.
Well, you're making me look bad because you sound fantastic and you look fantastic. And so everything you're doing is just hitting it out of the park. If my first episode was as good as you're doing, it'd be fantastic. So I wanted to start our conversation by framing the problem. Now, what makes rare diseases unique as a health policy issue in Canada? And feel free to bring in your own personal experience with your own children with regarding rare diseases.
Right. Well, that's the start point. I knew nothing about rare, including the example of PKU, or phenylketonuria, poisoning of the phenylketones, translated from the Latin, until our youngest child came into this world more than 38 years ago. And thanks to one of the modern miracles of health sciences through a program called newborn screening, his rare brain-threatening genetic disorder was discovered in the first days and weeks of life. And it's when you've got a problem, it's important to know exactly what it is. That's called having an accurate and timely diagnosis. And then you can, okay, you've got a problem. You're going to deal with it. And we've had a very good outcome. There have been some bumps along that road, and there are opportunities for improvement. But he is instead of being severely intellectually disabled, he is a university graduate and a first responder in Canada's largest city, living his dream. And my dad was a firefighter. That skipped a generation, I have to say. If you're in Toronto sometime and you see a fire truck with lights and sirens going, I strongly recommend that you get out of the way. My son might be driving it, and he drives that truck with a very heavy foot because he says, "Dad, they call us first responders. That means I have to get there first." So.
That is brilliant. So I'm glad that you started out with a story or a note of success, right? Not just sharing the personal story. I think it's fantastic about your son driving the fire truck. It's just brilliant. But even to get to that point, you said he was identified with newborn screening. So maybe you could share a few comments about some of the things that you've been very appreciative of, that you've said, wow, that really works. Thank goodness that exists.
Well, there's an example. It's newborn screening, which most people have never heard of, is one of the 10 top public health successes where it exists on the planet Earth. And it's not for everything, but there are some conditions that are hidden, and they can be doing damage in the background before the presentation of signs or symptoms. And the damage can be irreversible. So the best mom, the best dad, the best nurse, the best doctor, Dr. Wadley, you haven't got a chance if there are no signs and symptoms and there's irreversible damage taking place. So it's an early detection, early warning system saying there's a problem here, and you need to start intervening before the onset of classical presentation symptoms. Right. And in the case of PKU, the example is that, they're going to miss some milestones, developmental milestones in the first year of life. Oops, well, that's just an anxious parent. Would be, babies develop at different rates and stages and paces. So don't worry your pretty little head. And you don't have a chance now. So in Canada, this rolled out incrementally in the 1960s. And I knew nothing about newborn screening. I knew nothing about PKU until we had, and so I always had a feeling that I wanted to do something in life to say thank you to the total strangers who set up this early warning system for a recessive genetic condition that I had no idea, and my wife had no idea we were carriers of. And so that's what turned me actually into a patient health advocate much later, when I woke up one day back in 2005. And then the province of Ontario was doing newborn screening for two conditions. But I had read an article that they're due to advances in science and technology from the same drops of blood. The other jurisdictions south of the border, are you ready for this? Mississippi was using the same blood samples to test newborns for 30 conditions. And I said, well, I don't understand anything about this, but 2 versus 30, that doesn't look good. That doesn't make so. So I need to take a dive, all right, into this. I decided that's one. And long story short, we had a campaign and got to the Minister of Health in Ontario. And by September of the same year, he announced that as he promised his premier the day before, he would take on Ontario from worst to first. Ontario was the worst jurisdiction in all of Canada and the United States back in 2005. And we're happy to say that it's the leading jurisdiction in Canada. And now they're using different tests and different methodologies, different knowledge, different science. They're using testing babies born in Ottawa today for 35 conditions. And unfortunately, one of the conundrums of Canada is a baby born today across the river from Ottawa in Gatineau will be only tested for fewer than 20 conditions. So that problem of differential and unequitable access to health care, in this case, I'm using the example of newborn screening, is a Canadian policy pandemic.
So I love the fact that you highlighted differential access. So right within the Canada Health Act, one of the 5 principles is comprehensiveness. So the concept that we offer a comprehensive list of medically necessary services, and then the concept of portability. So the idea that you should be able to take your coverage from Ontario into Saskatchewan, Manitoba. Now that works theoretically across the country except for Quebec. But anyways, you've highlighted a beautiful example of something that works. And I wanted to push back just a tiny bit on you. I think you may have said this facetiously, Dr. Watley, you wouldn't even know what's going on. I agree with that. But I wanted to, this is my pushback. This is my pushback. I don't know a fraction of what you know. And I tell all my patients who have rare diseases themselves, or their family members have rare diseases. I studied this like a maniac for a short time in medical school to pass an exam. I might see one patient in residency, maybe at a teaching hospital. I can go 30 years in practice, emergency medicine, primary care, and never see a patient like this. And yet you
Mhm.
spend the last 38 years studying, advocating for this, learning about it, lobbying government. So tell me about the challenge of you becoming an expert. You truly are an expert on rare diseases. I bet you even know probably more than most specialist physicians, and how that overlaps with the challenges you may or may not face with getting access to care or getting funding.
You're right in that I've had the opportunity to start by taking a deep dive into one of the 11,000 or so known rare diseases. I am by no means knowledgeable about all 11,000 rare diseases, first of all. And the other thing, Sean, I'll somewhat facetiously, I'll push back on your pushback a little bit by saying, yep, and you studied like a demon, and you had to pass a proficiency series of exams to become a fully qualified medical doctor. But correct me if I'm wrong. This is my partner happens to be a retired physician, and you can pass with 80% those exams, so that you can be wrong 20% of the time. And I think it's humbling and useful for those who have been highly qualified to remember that you didn't need to get 100% on every test. But when it comes to living the best possible life for people with rare diseases, the goal has to be 100% each time.
Mm.
All right, and there's the opportunity for improvement. There's the challenge. There's the rub, and yeah, the interesting thing is in part of this PKU cross Canada journey, I with two other parents. We were sitting around my kitchen table one day, and we said, we probably need some sort of group organization. And we look around across the country and we don't see anything. So, well, if nobody else will do it, we'll give it a try. And the interesting thing, I was the Canadian born parent there. The two other parents were not born in Canada. One
Mm.
was from Argentina and one was from Romania. And it takes some, they demonstrated with their lives and their families that they had some get up and go, and they chose Canada. And so we put together this small cross Canada nonprofit, which is now its 18th year. And I did it because my personal interest is my son, when he was 20 years old, and he is the chief executive officer of his life and his body and his brain, decided he wanted to try the first innovative drug for his disease, PKU. It
Mm.
was still in clinical trials. And I, being a dad, I said, are you asking for my help to get you a drug whose safety and efficacy hasn't actually been proven and hasn't been approved by any health regulator anywhere in the world? Is that what you're asking? And he said, yes. So I said, fine. All right. And uh, the amazing thing is I had a network in newborn screening, which was also a network in PKU care and treatment and research and development. And long story short, he entered a phase 3 clinical trial in Chicago. That particular trial was not available anywhere in Canada. And in 2 days, due to blood tests, we knew the drug was working and was working tremendously well for him. Most people have heard of blood sugars and diabetes and glucose and glucometers and that. Well, for a blood sample there may be 10,000 molecules of glucose or blood sugar that a diabetic would be concerned about. In that same blood sample, there might be one molecule of phenylalanine. So not only is the disease PKU rare, so is the frigging molecule. All right, and that becomes a technical and scientific challenge to find those rare molecules. And the problem with that particular molecule is it's really good at crossing the blood-brain barrier, and where it messes up the neuronal functions. It does damage to the neurons and the axons. And it's a slow poison. So a
Mm.
baby with PKU, born with an undiagnosed, untreated, will lose about 1 point of IQ a week in the first year of life. So 40 or 50 points of IQ gone permanently by their first birthday. So that's why um, newborn screening was started everywhere to find the 1 in 15,000 babies who have this problem, who are going to be severely damaged for life at an incredible burden to themselves, their family, and society, and an incredible missed opportunity to be a normal, functioning, contributing member of society. So
Mm.
that's the pitch for newborn screening for those things that are doing damage that's irreversible before the onset of classic clinical symptoms.
So you've spent 18 years with your organization lobbying, working, advocating. Unpack for us some of the roadblocks with respect to bureaucracy. So you mentioned that you got your son into a phase 3 clinical trial. So people listening will need to know that there are different stages at which something goes through testing. We test it in the lab, test it on mice, and then we test it, etc. So there are multiple levels. Phase 3 clinical trial is just before it gets out onto a larger trial, so that we can generally start using it. Um, but unpack for me some of the layers of bureaucracy, and not because I hate bureaucracy. I actually tend to have a love-hate relationship with bureaucracy. You need bureaucracy to prevent you from jumping off a cliff before you look. But if you have too many layers of bureaucracy, it's like wearing 14 seat belts when you drive your car to the corner store. And I think we're on the side of the 14 seat belts when it comes to Canadian healthcare. And the only time you see that is when you're trying to access care that's slightly out of the ordinary, specifically around rare diseases. So if you have high blood pressure or pain in your hip, most people won't notice this whole system that exists around them. But if you have PKU or sickle cell or something else, you're immediately running up against these different regulatory authorities and approval agencies. I wonder if you could unpack your experience with them and just give us the name of them and tell us what they do, and just with respect to your son's own care.
Well, let's start with a subchapter of newborn screening. The practice can be improved in newborn screening, and my son's original story is an example of that because you have. When I'm being kind and generous, I say it's good to celebrate the heterogeneity of clinical care. When I'm being less than kind, Sean, I say you guys don't know what you're doing uh, as a group. All right. And the example is that we don't have a set of guidelines for the diagnosis and treatment of PKU in Canada. There's a set of guidelines in America, which is now just last on its second edition. There's a set of guidelines in the European countries, which is now on its second edition. There's a set of guidelines in Australia, New Zealand, etc. And this goes back to a problem of being slow and a problem of not having the cats herded together to apply the best available understanding of the best available knowledge. And in my son's case, specifically, I went back and pulled. We had a really weird experience. We were. I have a distinct memory. Uh, Healthy baby, healthy wife, healthy delivery, healthy pregnancy, bundled up where I'd pressed the button for the elevator at Women's College Hospital in downtown Toronto to leave after, all right. And we had it wasn't our first kid, so kind of done the drill. And uh, just as the door of the elevator was about to open, a nurse in training said, "Oh, he hasn't had his Guthrie test," is the acronym. And we got and took the blood sample, and that's the test for PKU. All right, named after a Dr. Guthrie. And if that nurse trainee had been 10 seconds later, uh, we would have been on the elevator, door closed, and on our way. And would there have been a follow up? I have no idea. And then about a week later, we get a phone call from the family doctor's receptionist saying, uh, sorry to bother you, nothing to worry about, but take the baby back to the hospital. They need to repeat that blood test. Oh, yeah, tomorrow. And then a week later, oh, really sorry to bother you, nothing to worry about. They just want to be sure about something. They need to do another blood test. And then about a week later, I finally had put my thinking cap on and said, what is going on here? All right. And so I called the family doc's office and got the reception. Oh, Mr. Adams, so glad you called. I was just about to call you. You have an appointment tomorrow with Dr. Hanley at the PKU clinic at Sick Kids Hospital. Bring your baby, bring your wife, be prepared to spend the day. Oh, that's the first time I ever heard of PKU. All right. This is the clap. And this goes back to 1986. This is pre-internet. All right. The pre-internet is called the Encyclopedia Britannica, which we had at home. And that we get the two babies to bed, settled. We said, let's find out what's this PKU. We open it up and bang. There's a phrase: profound, irreversible mental retardation. First paragraph, dart right through our eyeballs, right into our hearts. We go crazy. Anyways, so that was my introduction to the knowledge of PKU. It's a classic on how not to break the news to a family that there's a test result, and it's not definitive, but there's a reason to do more investigations to avoid harm. And so there was and if he was born in Ottawa as opposed to Toronto, they would have pulled him in for diagnosis and treatment after the first blood test because it had a certain level of phenylalanine in the blood. But in Toronto, sick kids at the time, they waited. The level had to reach a higher level. So we had this discrepancy in the trigger for clinical intervention based upon the level of a blood test. And happy to say that the influence of American guidelines has trickled north, and generally speaking, the interventions happen now if it's at a lower level. So there's an example in my son's life, but also let's come back to the example of the first drug for PKU, because the frontline therapy for PKU is not pharmaceutical. Phenylalanine is an amino acid that occurs in natural protein in food, almost every food. And it can be neurotoxic if too much of it gets into the person's brain. And because of an enzyme problem, there's a regulation in the body, and most of us are okay. The enzyme looks after the extra phenylalanine. It never hurts the brain. In PKU, it hurts the brain. And so the treatment for PKU is, okay, you're going to stop eating protein. Oh, oops, that's not compatible with life. Oh, what can we have as a protein substitute? So back in the 1950s, the first protein substitutes were invented. They're medical foods, medical formulas, and getting access to them across Canada is a postal code lottery situation. And then the first drug comes along, and my son is an extraordinary responder to that particular drug. He no longer has any restrictions on what he can eat. He can eat as much protein as he wants. He just needs to take his pills every day. Um, that drug was approved by the US in 2007. It was approved by the European Medicines Agency in 2008. It was approved by Health Canada in 2010. And what year are we today? Oh, it's 2025. 15 years later, we still have one province in Canada, Alberta, which is not making PKU available generally, or making that particular drug available to PKU patients generally. It is making it available to those whose brains have been severely damaged for whatever reason. But for the ones whose brains have been protected and need daily protection from the threat of brain damage, it's not being made available. So we have the postal code lottery and the access to the first drug for this particular rare disease.
Before we pivot to costs, can you tell us who is saying no to access? You said Health Canada said yes in 2010. Who is saying no? You don't have to name the province, but what authority is
I love,
saying no? Is it the Ministry of Health? Is it
well,
a drug approval agency? Who is denying this?
uh, um, um, there were a series of no's is the short answer along the way, and we have different. Um, our big problem in access to new therapies in Canada is that we have more levels and kinds of gatekeepers than any other country on planet Earth. We have 5 different levels of a gate when we're talking about a new drug. Um, and we have a regulator for safety and efficacy and quality. And then we have a process called health technology assessment. And if you survive that, then you are sent off with government drug programs. You're sent off to an agency that bargains collectively on price and terms for all the government drug programs in Canada. And then private insurance is a different pathway. But you can get a agreement with that collective bargain agency for the government drug plans. But that doesn't get your product actually listed or reimbursed. Then you have to work out individual listing agreements with each jurisdiction in Canada. And sometimes they double dip in terms of price and conditions. And then when a doctor can consider writing a prescription and the patient can get it paid for. But then there's a fifth level. There's a federal tribunal that is in name is supposed to protect us from excessive drug prices. It has a fancy title, Patented Medicines Price Tribunal, and it's unique in the world. It's the reason I can say for certain that Canada has more levels of gatekeepers than any other country in the world, because there is nothing like the Patented Medicines Price Review Board anywhere else in the world. And it's daunting. And that's why a lot of orphan drugs for rare diseases don't even bother coming to Canada. It's intimidating in that in places like Germany and other places for meeting an unmet need for rare disorders. All right. As soon as the regulator says the drug is safe enough and it's
Hmm.
effective enough, then it can be paid for immediately while they go through these other processes, and then the price that at the end of the processes gets applied retroactively to the beginning, the first prescription, right? And there are adjustments made. That's an example of putting patients first. In Canada, we put patients last. You can't
Hmm.
get the drug paid for until every T is crossed and every I is dotted. And
Mhm.
that's why it can take typically 4 years from the application for a new drug to the regulator, Health Canada, until it's actually listed by enough provinces to cover 80% of Canadians. That's not even 100%. 100% is longer. I mean, in the case of the PKU drug, we're not at 100% at 15 years after the Health Canada approval. I'm a great fan of the articulation of Michael Sabia just became before he became Canada's chief civil servant as Secretary of the Privy Council under the current government, and said Canada suffers from a deficit of ambition.
Hmm.
We need to be much more ambitious about getting new knowledge and new therapies to patients.
This is the part I wanted to get at. So I'm glad you took the time to take us through those 5 layers. And that's the part that most people have no line of sight, um, no access to knowing about. I wonder if you could
Yeah.
now dilate a bit on costs. So, rare diseases cost an incredible amount of money. I've heard
Mm-hmm.
of hundreds of thousands of dollars for one treatment is not
Mm-hmm.
uncommon. I've even seen some therapies now over $1 million. I wonder if you could talk about
Mm-hmm.
costs and prioritization. If we are spending a ton of limited money on a very rare disorder, how do we make that decision?
Let's keep two concepts in mind. The easy one is cost. The one that's more challenging is opportunity cost. All right. What are you giving up if you're counting the pen? How many pounds are you giving up if you're counting the pennies? And we're really good at counting pennies, and we're really good at silos. All right. So let me cut to the chase here. The We have a particular variant in Canada of health technology assessment where and it's based upon um, a concept of how much is a life worth. All right. And that question gets answered in different ways in different forms. The question, if someone is killed in a automobile collision, there's insurance, and there is a process of evaluating the value of that lost life. There is a process for evaluating the if the person is severely damaged but survives, and they're going to be severely down, and they're going to need substantial supports for the rest of their lives. There is a process for evaluating that, and ultimately it goes to judges and courts if the parties can't agree on that valuation. Um, in health technology assessment, as practiced in healthcare, um, we started with a quality adjusted life year, that's the jargon, call it, of $50,000. Started is the key, right? That was in the 1990s. That is still the metric used by Canada's official agency that does drug health technology assessments and has not been adjusted. Um, um, Sean, are you prepared to work as a professional for the same fee scale as you had in 1990? And it hasn't been adjusted for inflation. It hasn't been adjusted for economic growth. It hasn't been adjusted for rarity. It hasn't been adjusted for severity. It's a very crude instrument, and it leads to crazy outcomes and recommendations. In the case of the um, first PKU drug, that uh, metric, artificially low metric, produce a recommendation for a very substantial price reduction. More recently, it has produced that same mentality and false metric, I will say, of a $50,000 um, quality adjusted life year, has reduced rec saying this would be cost effective if the price is reduced by 99%. But there was a recent case that was in the news. Here, I'm on Vancouver Island in beautiful BC, about a 9-year-old, now 10-year-old little girl with an ultra rare disorder that is life threatening, Batten's disease. And she was the only patient in BC with this disease, and she was on one of these very expensive therapies. And the issue, and she'd been on it for more than 6 years. And it's the first generation drug in a disease. It slowed the disease down. It didn't stop the disease, and it didn't cure the disease. It's a first generation drug. The and the There are 300 patients in the world on this particular drug, and there were originally start criteria and stop criteria way back when through the health technology assessment process, etc. And someone who had never seen this little girl as a patient, a committee made a decision that this patient wasn't satisfying the continued therapy the criteria, and met the stop therapy criteria, which is a death sentence for her in the short term. And the mother and the family rallied, and it became a huge issue that attacks. It identified one of the problems with the blob in the middle, as I call it. And BC has a program called Expensive Drugs for Rare Disorders, and they set aside some money for it, and they have a series of committees that review this. There were more than 55 healthcare professionals involved in this. Not one of those 55 ever saw this patient. Not one of those 55 had ever treated a Batten's patient. And of the 300 patients in the world on the therapy, this was the first time in our human experience that the funder stopped paying for the drug against the advice of the treating physician and against the wishes of the family. That was outrageous, in my opinion. Now, as it turned out, there are some experts in Batten disease who disagreed with the hidden, secretive process of the 55 medical experts in BC who met in secret, and who made recommendations they want the politicians to provide cover for their not fully informed decisions. Well, the group of experts who treat more than half of those 600 patients around the world wrote a letter to the BC Minister of Health and said, I'm sorry, the word is bullshit. Bullshit. Those criteria are old and out of date and were never developed to be, on the basis of say this is when it makes good sense to stop this therapy. Now, and so the Premier and the Minister of Health had the good sense saying there's a disagreement among experts. All right. Well, I say there's a bit of apple and orange there. There are the experts in the disease, and there's the experts in the bureaucracy. And that letter got to the heads of government, and it was a reality. It was a reality check, and saying your expert process isn't up to date. It's stale dated. Those criteria are stale dated, and you can no longer have plausible deniability to say, oh, we have to listen to the experts. We can't go against the experts. Well, the real disease experts are saying that there is no good reason to take this little girl off the therapy. And government drug programs are a form of drug insurance. Why do we have insurance? So you're covered when something really bad happens. Most of us have fire insurance on our homes, and we're happy that we never have the experience of a home fire. And we're happy with it, but you want to have it just in case. And we're all participating in a pool of insurance because this little girl isn't to blame for having inherited a bad gene, if I can put it that way.
I appreciate how you've laid out decisions being made by expert committees, groups of managers who are completely separate from the clinical care that they're making decisions on. Um, so I think that's a necessary feature that most people don't realize is the status quo. That's normal in Medicare, not just for rare diseases, but everywhere. If we can extrapolate your experience with rare diseases to the rest of the system. And I also like the fact that you brought out the notion that guidelines get out of date, and guidelines can provide a bare minimum, but in a rapidly changing environment, they are often out of date by the time they even get printed on paper. And so a lot of times I'm when I'm interacting with patients, I'll hear their frustrations and say, I can't believe I can't get this test. This has been basic in Mississippi for years, and we don't even have it in Canada. We just need standardization. We need you guys to get your act together and get on the same page. And I would say, yes, but be careful what you ask for. We need bare minimums, yes. And we also need to have the flexibility baked in to be able to say, okay, that guideline's a bad guideline now, and it's actually causing harm and not helping people any longer. So I'm glad you brought that out as well. As we're nearing the end of this discussion, though, I wonder if you could turn your mind to how you would change things. If you could do one thing to improve healthcare in Canada, what might that be, given your experience with rare diseases?
Um, we need an Orphan Drug Act, right? The world changed starting in 1983 when then President of the United States, Ronald Reagan, signed a bill creating the world's first Orphan Drug Act. These are small groups of patients with rare disorders. And it's challenging for scientists and investors to make major efforts with markets with small returns. And that law has been copied in Europe, it's been copied in Japan, it's been copied in Russia, it's been copied in China. Canada is the only developed country that doesn't have an Orphan Drug Act to cut the red tape and to create incentives and to do a better job of protecting intellectual property for new inventions and new ideas and new mechanisms, and to create incentives for scientists and investors to make large bets on small markets. I've had some personal experiences. I'm now officially rare, all right, myself. The good news is I was diagnosed with a rare cancer, a tumor in my small intestine. And the very good news is because we were doing a proactive investigation and having a scope of my small intestine for the first time in my life for a completely different reason, we found the tumor when it was really early. All right. And it's been successfully removed. And that has been a win for me and for society and for the healthcare system. But it took me saying I had another issue of chronic mild anemia. And I said, any chance I've got a leak inside, a slow leak? Shouldn't we be doing scopes, to get the camera in there, so just in case, right? Because we couldn't, and so I had the first ever scope of my small intestine, and completely incidental finding. There's something there. We have to biopsy it. Oh, it is cancerous. Oh, we got to take it out. All done here in Canada, and I'm lucky. This particular, it's called neuroendocrine. This particular cancer is more typically found when you're stage 3 or stage 4, multiple locations. It has spread, and I'm an interesting research subject because we know, in my case, exactly where it first started. we're going to try with some amazing scientists at Princess Margaret in Toronto. Want to try and figure out, why did my body decide to make this rare cancer?
Mm.
And if we can answer that question, I'm pretty sure there's a Nobel Prize in it, because it's going to give insight, not just for that rare cancer. It has the potential of giving insight into why different people's bodies make different kinds of cancers. And that is the leverage that comes in a breakthrough and a new insight in a rare disease almost always has major insights for other health conditions, including some very common ones. So if we can take a deep dive into a rare disease and really figure it out, and then it identifies new ways of looking at old problems.
As you were saying that, the thought came to mind that our whole approach to democracy rests on the participation of citizens. So it's a participatory democracy. And our whole approach to healthcare requires the participation of patients and their families and their caregivers. And so, in that sense, John, you embody really the ideal of what we would hope for when we think of patient and family and caregiver participation to the improvement, to the betterment of our approach to healthcare.
On your last theme, the democratization of it, and those, when democracy is under threat today in a number of ways, I think we need to wake up and realize that too much of the blob in the middleware in the Canadian healthcare system takes part behind closed doors.
Mhm.
Those expert advisory committees in Canada meet behind closed doors. Um, the pandemic gave us examples. I could zoom in to meetings of advisory committees at the US FDA. I could zoom in to meetings of advisory committees at the CDC, at least in the old days of and I could see, okay, I can see how they got there. All right. I might not agree with it, but I can understand how they got there.
Mm.
Some of these outcomes and recommendations, we can't see how they got there. And it's not good for democracy. It's not good for honestly, the credibility and the broad public support for the system when you can't see for yourself how. I can go to a meeting at City Hall. I can go to a meeting at the provincial legislature. I can go to a meeting on Parliament Hill. I can't go to a meeting of an expert committee at Canada's Drug Agency or at the BC program for expensive drugs for rare disorders. We're not allowed in the room. It's not an open process,
Mm.
and
Mm.
that's it's not in the best interests of healthcare. It's not in the best interests of democracy. That would be my
Yeah.
so that's my way of tying a few themes together.
John, thank you so much for joining us today, for sharing your insights and for all the work you've done. And to our listeners, if you've made it this far in the program, don't forget to hit like and subscribe and be sure to share it. For Macdonald-Laurier Institute, I'm Sean Watley. Thanks again for tuning in to Inside Policy Talks.